Welcome to my channel. Today we are going to a very important topic, ECG. It's a very complicated case, but we are going to make it easy for ourselves with easily mnemonics, with a very proper diagram. So let's see. ECG, how to read ECG? There is a mnemonic RAHEB, RAHEB, rate represent through R, and A represent excess, H represent hypertrophy, and E mean ST elevation, and B mean block. So first we have come to R rate. How to calculate the rate for regular rhythm? The heart rate is calculated as follow. You have to calculate small square in ECG paper and between two consecutive R, and then divide it through 1500. It will better for faster heart rate. Or you can calculate big square between 2R. Let's suppose there are 15 small square between R, so divide 300 through 15 through number of large square between two consecutive R waves. So it will give us the heart rate. Like suppose between two R wave there are number of square are 3, big square are 3, so divide 300 to 3, so heartbeat will come out 100. For irregular rhythm, if a patient have irregular rhythm, then you should to calculate 15 big square and count R wave in these 15 big square. Let's suppose there is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 big square, and now count R wave and then and this 15 big square. So 1, 2, 3, 4, 5, 6 big square is there. So then multiply it through 20. If there is 7 big square, then multiply it 7 through 20. If there is 8 big square, 8 R wave and 15 big square, then multiply it through 20. So the heart rate in this case, and 15 big square there is 6 R wave, so multiply 6 through 20, so the heart rate is 120 beat per minute. So this is the way for regular rhythm. For regular rhythm we measure the distance between R wave and calculate big square or small square. A small square we divide 1500 through small square, and big square we divide 300 through big square. For irregular rhythm we calculate 15 big square and count R wave in these, and then multiply it to 20, so the heart rate is come out as 120 beats per minute in this case. The third thing is ECG rhythm. As we discuss through mnemonic, rahib, rate, and rhythm. So now to find the rhythm of ECG, look for RR interval, the distance of every R wave best seen and lead 2, a stressing lead. So we take lead 2 and take a piece of paper, either by a ruler or take a piece of paper, mark the interval between RR and compare with another RR. If both are same, you have a sinus rhythm, regular rhythm, as it's explained here in Urdu, that take एक कागज़ लेते हैं और एक आर से दूसरे आर तक के फासले का कागज़ पर लेते हैं, मार्क कर देते हैं। अगर और वो आर इंटरवल पे दूसरे आर इंटरवल के साथ हम कंपेयर कर देते हैं, if there is same, it's regular rhythm. So if patient have irregular rhythm, so what will be the outcome? So now if the patient has regular rhythm, they look for presence of P wave. If there is presence of P wave, it's a sinus rhythm. If the distance between RR is not constant, we call it irregular rhythm. If there is absence of P wave, then it's called atrial fibrillation. If you find the rhythm is totally irregular and there is no P wave, this is called atrial fibrillation. So irregular rhythm plus F and P wave is called atrial fibrillation. And causes of irregular rhythm. So no ECG axis take lead 1 and AVF. Normal axis of FQRS and both are upward, as in looking in this case in 1 and AVF. Now come to the abnormal condition and 1 and AVF if both QRS reach to each other, as in this case we are seeing. So reached, you can take the R and right axis deviation. It's happen in right axis deviation, both QRS reach to each other, and mostly you can see it in feeder wall MIE. And suppose it is if both QRS leave each other. So take L from leave and I mean its left axis deviation. So it's a very easy mnemonics. You can see through lead 1 and AVF. Waves, there is a normality P wave represent atrial depolarization best seen in lead 1 and 2, and lead 2 looks along the atrial axis, V1 look across the atria. P wave normality, this star symmetrical P wave seen in the increased right atrial pressure, people model. It's a tall talented P wave. It's deep P pulmonale. If it's notched wide wave seen, its left atrial pressure P mitral is seen here. Bipedal P wave can occur in both right and left atrial dilatation, typically appear in lead 1 and 2 as seen in this case. PR interval at represent the time between the onset of atrial depolarization to the onset of ventricular depolarization. It contains the entire PO as well as subsequent brief isoelectric period. PR segment, as you seen in this picture, it represents the delay conduction within the AV node bundle of Hess branch of Purkinje fiber. As you may know, duration is 0.12 second to 0.2 second, less than 5 small square from onset of PO to onset of QRS complex. Note this interval is rate dependent. It will shorten with faster heart rate. What happens if there is a prolonged PR interval? Normal variant first degree AV block. It's occur in drug like digoxin, verapamil, diltiazem, calcium channel blocker, hyperthyroidism. It's a very rare case. It can happen here. It's also certain abnormal PO, then consider retrograde atrial as in this case. QRS complex, normally steady progression from E1 to E6. It is steady predominantly downward S wave from V2 to V6 at progress to upward. Duration should be 0.08 to 1.1 as you look at this diagram, the first, second one, and V2, V3, it's going steadily downward, progressively enlarged from V1 to V2 as progressively enlarged. This is the other DD nomenclature. Low voltage QRS complex less than 5 small square, and most of the lead pericardial effusion, myxedema, emphysema in this disease. It's a low voltage and high voltage. It's occur in ventricular hypertrophy, right ventricular hypertrophy, tall in R in V1, and left ventricular hypertrophy. You can see tall R wave and V6 and deep S1 and V1 and R in V6 and S in V1. 7 large square its size, and wide ventricular origin are bundle branch block. This is a tall R wave and V1 voltage you can see here.